cardiac surgery program started in the early 80s and has grown to over 1,000 cases a year, with another 500 structural cases and another 600 thoracic cases. The surgery ranges from valve repairs and replacements to coronary artery bypass, arrhythmia surgery, and cardiac oncologic surgery. We are a top 5% performing program in the country from STS data, and we have all of the subspecialties of cardiac surgery, including valve repair, valve replacement, structural heart procedures, minimally invasive. For thoracic surgery, we have the wide range of thoracic oncology, anti-reflux surgery, and thoracic tumors.
So when I came here, there was a bit of individuality that people were doing things without discussing them and everything. So we put together something that we saw this morning, our huddle, which we do every Monday and Friday, where the whole team gets together and looks at all the patients on the service. And we sort of have a philosophy that all of us are better than any one of us. So we look at everything and we get ideas from each other. And that goes for the patients, for the ICU, and particularly in the operating room. Our operating rooms are on the same hallway. We're all right next to each other. We go back and forth between the rooms. If someone's having a challenging case or whatever, we're all in there working together to try and solve the problem.
Even though all of the surgeons can do all of the procedures, we decided that it was best to have one person doing a lot of one thing rather than multiple people doing a little bit. So, for example, the minimally invasive cases have all gone to me, and I've developed the minimally invasive program over the last 10 years. We started out with doing 25 cases a year, and we're doing over 150 cases a year of mini right thoracotomy surgeries. In a similar fashion, we felt that it was best to get one person doing a lot of the aortic surgery. We're really focusing Dr. Walker on doing a lot of the big aortic cases since her training was specific to that.
One of the procedures that had never been done here at our institution that I brought was something called the Florida sleeve that Dr. Martin and his team developed up at University of Florida in Gainesville, and it's a valve-sparing root repair procedure that nobody here did. Prior to me coming, most people that had root aneurysms wound up with root replacements, with the exception of a couple Davids that were done. One of the things I'm most proud of is the cardiogenic shock protocol that we've been developing, that I have come up with one of our heart failure cardiologists and one of our interventionalists to kind of really bring our program more into current method.
So my role at SMH centers around cancer surgery of the chest, predominantly lung cancer surgery. Since coming here, we brought in a new technology that allows us to basically personalize the operations that we can do for patients with early stage peripheral lung cancers. And so this technology takes a regular CAT scan, which is 2D imaging, and puts it into 3D reconstructions so that we can then see the location of the cancer and the specific patient-specific anatomy that leads to that segment, so that we can then design an operation that removes that segment of the lung with the cancer and incorporating all the lymphatic drainage with that resection. With the standard imaging, I can guess where I think that nodule is and what the segmental boundaries are, but I have no way of really knowing. But once I put it into the 3D reconstruction, then I can see very clearly, and it adjusts the operation that I do for the patient based on those boundaries.
I've been blessed to have an incredibly wide-ranging experience across almost 3 decades now, but I've pretty much focused down on coronary bypass surgery. I've branched into electrophysiology, structural heart, honing my skills in catheter and wire-based technologies. And recently, over the last half decade, I've picked up the skills to do laser lead extractions, along with reimplantation of devices, which is not typically seen amongst surgeons.
The future of valve surgery is going to be transcatheter. I think that there'll always be a place for surgeons to be operating, but I think the more and more as the technology develops, transcatheter-based approaches are going to become more prevalent.
I think that we're going to get smaller and smaller, and likely as screening becomes more engaged, I think that we're going to identify lung cancers that are so small that we may not be doing operations through the chest wall, but instead doing operations through the airway. So it'll be true incisionless surgery.
I think as the program continues to grow, we're going to start looking more into research. We are already involved in multiple trials between cardiac surgery and cardiology, and we have a research center, and we're going to keep pushing that so that we can get involved in more trials.
I think that everything we've accomplished has been due to all of us being able to put it together. And that includes not just the surgeons on the team, but the way we've been able to put together a good group of physician assistants, an excellent nursing team in the ICU and the floor. So we've put together a lot of things that have made it very good for the patients, for their families. And I'm most proud of the fact that we've maintained a sense of the most important thing being the quality of what we do.